Good evening, everybody, and you're all very welcome here. I'm going to talk about a few subjects, a brief kind of overview of a few of them. Some have overlapped a little bit with some of the earlier speakers, particularly the overactive bladder. And I hope that you all get something to take away from that may be useful to yourselves, and certainly things you can bring up with your own doctors. The first topic I'm going to talk about is OAB, and there's always lovely pictures when you go looking for pictures for presentations. The bladder itself, as most of my talk is on the bladder, is a muscle. So its function is to store urine. Urine is produced by the kidneys. It travels down the ureters into the bladder, and then at a socially convenient time, the bladder empties of liquid, which is urine. The overactive bladder syndrome is a constellation of syndromes. The most predominant symptom is urgency. This occurs with or without urine leakage. It's usually associated with frequency, and there's a few different definitions of frequency. The one we use mostly is going to the toilet more often than normal for you. And the average, as Lindsay mentioned earlier, will be 4 to 6 times a day, depending on your fluid intake. Nocturia is getting up at night time. Many women, as they get older, would get up at least once, but more than once is not normal, and therefore we would define it as nocturia. Urgency in itself is a very distressing symptom. It's a sudden compelling, it overwhelms everything. It's a desire to urinate, desire to go to the toilet, and it's very, very difficult to defer. It's not just a sensation that I must go to the toilet, I have to go to the toilet, or I'm going to leak, or I get very uncomfortable from it. When you leak with this symptom, we call it urge urinary incontinence, and this is just helpful from a medical practitioner's point of view to define the different types of incontinence to do then tailored treatment. But it's an involuntary leakage of urine, and it is usually almost always accompanied either at the time or right before with that sense of urgency. So the normal bladder, it fills up with urine to whatever its capacity is, usually about 350, 400 mils, and the transducer muscle is nice and relaxed. Then you go to the toilet, then the muscle contracts and you empty your bladder. In the overactive bladder, this contraction will occur anytime it wants to, and usually socially inconvenient. When you have this symptom or this problem, and if it's a bothersome problem, you will hopefully come to see your doctor. And at your first visit, the doctor will attempt to look through your symptoms and hopefully tailor an initial treatment. Some of this I'm hoping that you'll be able to take away yourself and start, if you feel it's an issue for you, start yourself today. You'll always have a physical exam, so be reassured that we'll check out to make sure nothing else is wrong. We always check your urine to make sure you don't have an infection or any other condition that could be causing your symptoms. And a very useful thing to start off with is to fill up a bladder diary even yourself, and these are quite easily available, or even just fill out yourself with a column of writing down what you drink, how much of it you drink, how often you go to the toilet, and again a plastic jug, as Lindsay mentioned, to measure how much urine you produce. And it's quite interesting, a lot of women will come back saying, I never realised, so often with such small volumes, and you may discover that you're actually drinking way more than you would think you're drinking. Once you have this filled up, you can modify your own fluid intake yourself if you wish, or bring it to your GP or to one of our nurses. Again, you may be drinking too much, you may even be drinking too little. The average fluid intake a day that is necessary for your body is about 1.5 litres of fluid. And don't forget that most of what we eat in terms of fruit and food and vegetables and meat is also high water content. So we absorb a lot of fluid from our food as well. We often discuss weight loss, and this is certainly an issue when it comes to female pelvic floor dysfunction. And certainly weight loss will help some of your urinary symptoms, and this is often discussed if your body mass index is over 30. And again, the Irish are a great nation of tea drinkers, and there's a lot of research showing that actually tea has a worse effect on your bladder than coffee. And certainly if you're drinking 5 and 6 cups of tea a day, which you mightn't think you're drinking until you actually take this down and write it all down, you may discover that reducing some of this tea intake or switching to a decaffeinated form of tea will help your symptoms, which is a very basic thing to start off doing. I'm quite fond of bladder training, and it's something that you have to kind of buy into a little bit. It's about retraining your bladder. Your bladder over time can get into quite bad habits, so you've modified what you're drinking and you're still having symptoms, and it's about kind of saying to your bladder, it's time for me to take control back, I'm going to be in charge of me now. And the basic bladder training is once you fill up your frequency volume chart, if you discover you're going to the toilet very often with only small volumes, but then maybe first thing in the morning your bladder can hold more, and you know your bladder can hold more, you start to say to your bladder, it's not time to go yet, it's only been 2 hours, I know I can hold on longer than this. If it's been more than 2 hours, go ahead and empty your bladder and feel comfortable. If it's less than 2 hours, you need to say, no, not yet, thank you very much. Sit down. This takes some of the pressure of gravity off your bladder and gives your bladder a bit of a break. contract your pelvic floor muscle, and this is very important because once a little bit of urine enters into the urethra, it stimulates the bladder to contract. It's very, very hard to defer it after that. If you sit down for 2 minutes, you give your bladder a chance to contract, and then it has to relax before it can contract again. When you've that 2 minutes over, take yourself nice and slowly off to the toilet and take your time. Most women won't leak once they've gotten rid of that intense urge, and then by the time you get to the toilet again, you're ready to empty your bladder without that urge. If lifestyle changes, if your fluid intake changes don't change your symptoms and you're still quite bad, there are medications, and there's a number of medications available. There are more drugs coming online the whole time. They can be taken in a tablet form or in a patch which is applied to the skin. One of the problems with them is there can be some side effects from them which can be a bit distressing. The common side effects would include a type of dryness, so you get dry eyes, dry mouth, sometimes a bit of nausea and constipation as well. In women who've gone through the menopause and have quite dry tissues, a very dry feeling in the vaginal area, local estrogen in the form of a small estrogen tablet just placed into the vagina can be very useful for both the dryness feelings and also some of the kind of frequency urgency symptoms as well. Overactive bladder can be a type of a chronic condition. It can be lifelong, but there's a lot of things you can do to modify its impact on you. And also many women will find that they go through periods where actually their bladder is good, having a good year or bad year, good month or bad month, and times where it's getting worse again. So kind of try and keep going with good habits and healthy habits. It'll certainly help you along the way. Now, the next, I suppose, topic I'm going to discuss is a rather difficult one to fully explain. The bladder pain syndrome, interstitial cystitis, is a condition that has been around a long time. We're really only getting to know a little bit more about it, and certainly only at the tip of trying to work out how to treat it. It's a very debilitating disease, and it presents with a lot of symptoms, but predominantly there's a pelvic pain issue. It's associated with pain with urgency, frequency, nocturia, and usually going to the toilet quite often quite small volumes. And this is very much a diagnosis where we've ruled out a lot of other things. We've ruled out infections, we've ruled out any other gynecological problems, and we're left with this constellation syndromes. There's no diagnosis for it. There's no one test that will definitely confirm that you have this, but it's a very common condition. Overall, almost 40% of women have pelvic pain, so that's quite a considerable amount of our population. And up to 12% of those may actually have a type of bladder pain syndrome or interstitial cystitis. It's commonly associated with irritable bowel syndrome as well. And for it to be diagnosed, it can't just come and go this week. It has to be present for at least 6 weeks. And in this particular syndrome, the pain typically worsens as the bladder fills and is usually relieved after it empties. It may indeed in women fluctuate with the menstrual cycle, and like overactive bladder, this is also present in men. And again, a bit like overactive bladder, the symptoms can vary quite a bit, and you can have good time and bad time. Symptoms can be very different between women and men, and also for the same person at the month, and during the month can have different symptoms as well. One of the biggest problems with it very seriously affects the quality of life for patients, and it's been described as patients would find their quality of life as worse with painful bladder syndrome than actually on renal dialysis. It curtails job work, leisure activities, family activities. It can cause quite distressing pain during intercourse. It can cause a type of fatigue syndrome, and it certainly leads to unnecessary operations trying to find a cause for pain, and significant amount of money can be spent on trying to find a cure for it and manage it. Because we don't really know what causes it, it can be a little bit hard to diagnose, and it's often a condition that we find by outruling other conditions. So we need to outrule urinary tract infections, overactive bladder, other gynecological problems, stones in the kidneys or in the bladder, and also we need to outrule malignancies, so any types of tumours that may occur. The management initially, there's a very good website, which is the interstitial cystitis website, that looks at diet, and this gives a list of good foods and bad foods. No more than caffeinated drinks can irritate the bladder. There's a number of drinks, foods that can irritate your bladder, and often avoiding these or switching to different types of foods can help your symptoms. And from a painful bladder syndrome point of view, it's all about managing the symptoms. We can't take it away completely. Physiotherapy is very useful. There's a lot of muscle tension, spasms caused by this. A lot of it is helped by stress and life management, and also by pain relief medication. There's a number of drugs here that are act both on the brain to help decrease the perception of pain and directly on the bladder. These are taken, some of them are tablets, and then there's a number of therapies that can be given into the bladder directly, which act on the bladder surface itself. One of the common ones we use in Ireland here is hyaluron or cystostat. And then you're really moving on to surgery, and the surgery is can be quite invasive. There are some people would have ulcers that need to be resected from the bladder, filling up the bladder and making it kind of over-distend a little bit, and then quite, Botox can be useful to paralyse the bladder and get rid of some of the frequency, and neurostimulation and major surgery will be actually taking out the bladder itself. So it's quite end-of-line stuff for very, 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 very badly suffering women. It really is a chronic and a severe disease, but it's just important to emphasise that it can significantly influence daily life. It has quite an impact on your activities, and so that we'll continue to have a lot of research into it, and hopefully we'll have some more treatment options in the future. The last topic I'm going to discuss is again another common topic. It's recurrent urinary tract infections. We call them UTIs for short, and UTI is an infection in the urinary tract. Infections are caused by microbes, which are organisms that we can't see without a microscope. Bacteria, fungi and viruses. From a urinary tract infection point of view, bacteria are the most common cause. Normally bacteria that enter the urinary tract are rapidly removed from the body before they can actually cause any symptoms. Sometimes the bacteria themselves overwhelm the body's natural defences, and that's where you start getting infection and symptoms from it. When it comes to recurrent urinary tract infections, you need to have 2 or more infections in 6 months or 3 in a year before we kind of define that you've recurrent infection. So 1 is common, 2 not so common but kind of still be normal, 2 or more, 3 or more is recurrent. Now, mostly they're caused by bacteria, and the commonest one is E. coli, which is a bacteria that's found in the bowel. Urinary tract infections themselves are the second most common type of infection in the body, so they're very common. Women are particularly prone to them because of their anatomy. So a woman's urethra is short, it allows bacteria to quickly enter into the bladder. And it's also very close to sources of bacteria, so both the back passage and the vagina. And half of all women will have a urinary tract infection at some stage in their lifetime. Now, although everybody has a risk, some women are more and men are more at risk of getting infections than others. So people with spinal cord injuries or nerve damage around the bladder, they have difficulty emptying their bladder, allowing stasis and pooling of urine, which allows bacteria to grow in the urine that's actually not emptying. Anybody with an abnormality of the urinary tract that obstructs the flow of urine, so kidney stones, or in men enlarged prostates, are at risk of a urinary tract infection. And then people whose natural immunity is a bit lessened, so diabetes or any autoimmune disorders, are much more likely to get urinary tract infections than the general population. Now, women particularly are prone. Sexual activity can move microbes from the bowel or from the vagina to the urethral opening. And following intercourse, women have a significant number of bacteria actually in the urine. However, the body's pretty good at getting rid of most bacteria, and most are clear them within 24 hours of sexual intercourse. 20% of women with a urinary tract infection will have a recurrent infection, and the problem is that with each urinary tract infection, the woman's individual risk increases of having further infections. The treatment is fairly straightforward for an uncomplicated urinary tract infection, and most women have uncomplicated ones. It is important, if you're given an antibiotic, to complete the full treatment, because certainly your symptoms will often improve before the course is finished, but the infection may not be fully cleared, and this is often why you need to have a recurrent course quite soon after the first one. If you do have recurrent urinary tract infections, which again is more than 2 in 6 months or 3 in a year, there's a few different things you can do. The first is to try and take a low dose of an antibiotic daily for 6 months. We often suggest you take it at bedtime because the medication stays in the bladder longer and it might be more effective this way. And this therapy is very effective without causing any serious side effects. If it's mostly infections from after sexual intercourse, then often taking a single dose of an antibiotic after sexual intercourse and emptying your bladder is very effective. And also then not taking the antibiotic continuously, but taking a short course of 2 to 3 days when your symptoms appear can also be effective in preventing getting a full infection. Now, how can you prevent infections? And this is really where kind of the most important things are. The first thing is, and a little bit of contraindication to the overactive bladder problems, is to drink plenty of liquids, particularly water. So water helps dilute your urine. So if you do suffer from recurrent infections, it is important to give up your fluid intake and not to fluid restrict. So this allows the bacteria to be flushed out of your urinary tract before the infection can actually begin. And again, when you feel the need to go, don't be holding on, empty. Now, very simple and something we teach children, but we often do forget this, is important to wipe from front to back, particularly after urination and definitely after bowel movement, again to prevent the transfer of bacteria from the anal region up to the vagina and into the urethra. Also said for women who particularly who get recurrent infections after intercourse is to remind them to empty the bladder after intercourse and also drink a full glass of water, which will help flush out the bacteria. Now, something else that you certainly will see in shops is an increasing array of deodorant sprays and feminine products for the vaginal area, including douches and powders, and all these do irritate the area, and if you irritate an area, it's more likely to become infected. Cotton underwear and loose-fitting clothes to be worn so that you can keep the area around the urethra dry. Tight-fitting jeans and nylon underwear can trap moisture and certainly give a bacteria kind of a head start. And also, leaving underwear off at night time is a very simple way of making sure that the area is well aired. If women are postmenopausal, if you're feeling quite dry below, vaginal estrogen therapy is also a very effective way of decreasing the recurrence of urinary tract infections. Now, I suppose it's important to remember that some women have 3 or more urinary tract infections a year. However, very few women will continue to have infections throughout their lives, and what is very typical is you'll go through a year or 2 of having infections, after which they'll settle down to maybe 1 a year. Yep, thank you very much.